Now let's welcome Qingyun, the speaker for the last talk titled Augmented Reality-Based Guidance with Deformable Registration in Head and Neck Tumor Resection.
Hi everyone, my name is Qingyun. I am a fourth-year undergrad at Vanderbilt University in the United States. Before I start, I do want to give a little disclaimer that I did not expect that this talk is right before the lunch session. Some of my slides include pictures and videos directly from cadaver studies, so if that will make you feel uncomfortable, please feel free to look away. Today, I will be presenting our work, Augmented Reality-Based Guidance with Deformable Registration in Head and Neck Tumor Resection. The focus of our work is on head and neck squamous cell carcinoma. In most of the cases, the patients who undergo surgical resections aiming for a complete removal of the tumor. This is how the general clinical workflow goes. The surgeon will finish an initial resection in the operating room. Then this resected specimen is sent to a pathologist for a frozen section analysis. If the tumor is detected at the edge of the specimen, then we define this edge as a positive margin. The presence of a positive margin usually indicates that the surgeon might cut through the tumor and there's more tumor cells left in the patient's body. In this case, the pathologist calls back to the operating room, give verbal instructions on the location or the distance the tumor to the edge of the resected specimen. For example, this is a note I took when I am observing a real head and neck surgery. The pathologist just reported 0.6 centimeters lateral margin. Then, the surgeon needs to relocate the possible tumor location on the patient's body. However, this relocation task is very challenging. There is research shows that almost 80% of the patients with an initial positive margin still had it remain positive after a re-resection. There's two challenges that the surgeon faces during this clinical workflow. First, mucosa specimen can undergo 10 to 47% shrinkage after the resection. This makes it hard for the surgeon to build correspondence between the shrunk resected specimen the pathologist sees and the resection site the surgeon sees. Second, most of the head and neck specimens, they have very complex 3D shapes, and mapping them back onto the resection site, relying only on the distant information through verbal instruction is very difficult. Targeting on challenge number 1, we previously proposed this deformable registration framework that corrects the intraoperative deformation happen on the resected specimen by registering the backside of the specimen back onto its resection site point cloud. However, we observed that this framework did not perform well in specimens with convex shapes, like ton cases. In the video below, we observed that the ton specimen offered deformable registration aligns well, like one side of that specimen aligns well with the resection site point cloud. However, we observed that there's excessive, unrealistic deformation happen on the other side. Targeting on challenge number 2, we previously proposed a augmented reality guidance system. In the video, the surgeon wearing an AR display is mapping the specimen back onto the patient's body. However, the limitation of this work is that the manual adjustment is required. However, it's difficult to conduct during the surgery. To address all these challenges, we propose a new framework that integrates these two work together while addressing all the limitations mentioned above. For the deformable registration component, we add in a pre-resect surface as an additional constraint to guide the deformation of the other side of the specimen. And for the AR guidance component, we use a automatically HoloLens detectable auricle marker to achieve automatically mapping. I'll go through each component one by one. So for the deformable registration, before the resection, we ask the surgeon to mark the area they plan to resect, and add 4 pairs of stitches. These stitches are later used as fiducial points. Then we use a Z camera to scan the surface the surgeon marked, and this is our pre-resect surface. We would manually label the stitches, and these are shown as blue points here. After the resection, we'll go over the same process to obtain the post-resect surface as well as fiducial points. We utilize these fiducial points to rigidly align these two point clouds together, and this formed our target point cloud that will be later used to guide our deformable registration. For the resected specimen, we use a 3D scanner to obtain its 3D mesh, and also we manually label the stitches on the specimen, as shown red points here. We would first rigidly register the 3D mesh of the resected specimen and the target point cloud together using the fiducial points I just mentioned. Then we apply a regularized Kelvin-Litz-based deformable registration method to reconstruct the specimen model. During this process, we are trying to minimize 3 terms: the distance between the fiducial points on the resected specimen and the target point cloud, the distance between each surface point on the resected specimen and the point cloud, as well as a strain energy penalty, which is to ensure the deformation is physically plausible. We utilize a leave one out method to evaluate the accuracy of our registration method. So basically in here, we exclude 1 pair of fiducial points as target and perform the deformable registration using the rest 3 pairs. Then we measure the distance between the target points on the resected specimen after deformation and the resection site, and use that distance as our target registration error. So here's our result. We compared our proposed deformable registration with 2 rigid registration methods, as well as with our priorly proposed deformable registration, which utilized the post-resect surface to deform only. We compared, this is the overall target registration error across all specimen types. We observed that the 2 deformable registration methods outperform the rigid registration methods. Although our proposed method shows a comparable performance with the prior proposed deformable registration, there's one thing to notice, that in some clinical more challenging cases, like tongue cases, the proposed method outperformed the prior proposed deformable registration in all cases. This highlights the importance for us to use specimen type-specific deformable registration strategies. For the AR guidance component, we first attach a aruco marker next to the resection site. Then we record the relative position between the aruco marker and the resection site fiducial points. We then rigidly register the resected specimen back onto its resection site, thus we can obtain the relative position between the aruco marker and the resected specimen. We deploy our resected specimen model back onto the resection site using the AR display and utilize the relative position we just obtained. And thus, we can achieve a automatic mapping in real time. And here's a demo for it. So based on the feedback from our collaborative surgeon, we also add a feature that allows us to adjust the visibility of the resected specimen. We evaluate the performance of our AR guidance component using a user study. In this user study, we choose 1 fiducial point on the resection site as target, and then we record this target point's location. We then removed all the fiducial points and ask our user to place a pin to relocate this target position while we are giving them verbal instruction only. We measure the distance between this pin location the user placed and the recorded target position, and use that as our target relocation error. Then we ask the user to do this task again, but this time with our AR display guidance. The table below shows the result for that. In all cases, the user with AR guidance outperformed their previous performance with verbal instruction only, which shows the effectiveness of our AR guidance. So in conclusion, we propose a new framework that integrated deformable registration in AR guidance system. Our deformable registration achieves a more accurate 10-case registration. However, this highlights that we need tissue type specific modeling for our future work, targeting according to the different characteristic that the specimen has. Our AR guidance system shows its potential to enhance spatial understanding and potentially improve the re-resection precision in head and neck surgery. Thank you so much for listening.